Next, we have a 52-year-old female who presented to us with a painless progressive jaundice for past 2 months, for which she underwent ERCP initially, but later on that plastic stent got blocked and again came with the complaint of jaundice. So this time ERCP got failed because of the duodenal obstruction and she underwent PTBD and a plastic drain was put. Now she is having nausea, vomiting for past 15 days. She has come for EUS guided gastrojejunostomy, basically for the palliation. She has refused for the surgical management. And so I would like to request Dr. Pravir Rai to please start the session.
Okay, so again, this is a 50-year female, and as you mentioned in the history, the patient is having a ampullary mass with biliary obstruction, with outlet obstruction. Initially underwent an ERCP with a plastic stent, following which she developed stent block and outlet obstruction, underwent PTBD, and now the procedure is primarily for palliation of outlet obstruction. So what we have done is we have passed the scope down into the stomach. From the stomach, we are trying to visualize the small bowel, predominantly jejunum, and we have instilled saline mixed with contrast and methylene blue. The purpose of saline is primarily to distend the bowel. The purpose of methylene blue is that when we deploy the stent, we should be seeing methylene blue coming into the stomach. That confirms that we have deployed the stent right. And the contrast is primarily for visualization of the bowel loops on fluoro. So as you can see on EUS, is the EUS image visible there?
Yeah, Pravir.
Okay, so we are, can we just distend now? So you can see we have a bowel loop there. And what I'll do, I'll instill fluid. And as I instill fluid, you will see the distension occurring, some movement occurring in this loop, which indicates that this is the small bowel loop and not a colonic loop. So as we keep on distending, what we want is a well distended bowel loop. Otherwise, the procedure becomes very, very difficult if you don't have a well distended bowel loop. Yes.
Hi, Pravir. Saurabh Kewar here.
For one reason, because in this case, there is an artifact. This artifact is giving trouble. You are mistaking this artifact. So I will apply in this case tissue harmonic. Hopefully, that by applying tissue harmonic, this artifact will disappear. Yes.
Hi, Pravir. I had a question. What size of the drain are you using to distend the bowel? Are you using a 7 French nasobiliary drain or a larger one?
Yeah, so in this particular patient, it's a 7 French endoscopic nasobiliary tube that is being used. As you can see now, the bowel is being distended. You can see volvular conventives running across, the fluid moving in. So we are pretty certain that this should be a small bowel loop and not a transverse colon or a colonic loop. So here, one thing is important, that you want a distance of at least 4 centimeter for your the cautery enhanced stent to enter into. So that segment should be available before you think of puncturing. So Sony, just freeze this and can we just measure the size?
Can we see the fluoroscopy view just to get an idea where your stomach is across the gastric lumen?
Just measure the size, length between the probe, between the this to this. Just measure this. Oh, further below. Yeah. Okay. So this is around 3.3 centimeters. I definitely need a centimeter more to be certain that my delivery catheter goes in deep enough. So just defreeze this. Okay.
So you are saying this is not vertical, it is has to be oblique. Yeah, now this is
so yeah, I think this looks okay. So basically when you
this is now okay. Because from here, if I will keep from here, the needle will come out from here, and what I have to do is
device.
Yeah. But the only thing is all this, yes, yeah.
Give me the device, please.
Device.
Flush with fluid first.
So Praveer, there have been some recent, there's even a paper talking about the angle of placement of the lamps. And I think getting a straight angle is sort of more desirable than being perpendicular to the bowel loops.
So ideally what was talked of that you should be perpendicular to the bowel, and that's primarily you want to enter into the bowel in one go. So that's what is needed. You want to be perpendicular to the bowel. So to be honest, being exactly perpendicular never happens. Flush हो गया? इसको हटाओ. Flush कर दिया ना? So we can just put in the fluoro so that we are able to see where exactly we are puncturing. So fluoro, please. Okay. Okay. Sure. Doppler, please. Doppler. बस हटाओ. नीचे. So we are ready. All set. The bowel looks distended and looks sufficiently distended. So the first step is primarily the entry into the jejunal loop, and we have applied Doppler. We are convinced that there is no large vessel in the wall, so things look okay. We unlock this delivery catheter has got 4 marks, 1, 2, 3, 4. We have done unlocking, and then after unlocking, the first step is passage of the catheter. So we are out. As you can see, are you able to visualize the?
Yeah, we can see the catheter. Yes.
Yes.
I think that's a
So,
looks okay.
400. Okay. Fluid on, please.
And the
okay.
cautery settings you use are similar to sphincterotomy.
No, so this is a pure cut, what we are using. So we are in the bowel. This was the first step. So second step is deployment of the distal flare. So now the whole assembly is inside along with the stent. We intend to deploy the distal end. For that, I have removed the yellow stabilizer, which was a yellow blocker, which was there. And then we have unlocked, and then we will deploy the distal end. So we'll deploy just by pulling it back. So as you can see, we are pulling back, pulling back, pulling back, pulling back. And now can you see the flare?
Yes,
Can
yes,
you
we
remove
can
the
see it.
Doppler, please?
Nicely done. Yeah, we can see it.
So now you can see we are just seeing arm of the flare, that other part is being shadowed, but that's okay. So next is the third step. So for the third step, we need to position this distal flange. You can just unlock this. So the issue is this stent is just a 1 centimeter stent, and you have to ensure that the bowel, the stomach as well as the small bowel loop are very close together. So now we have deployed the distal flange, opened up the distal flange. And now what I'll do is I'll just try to position it right. And by this, I will just unlock this again, push this up, push this up, push this up. So as you can see now, it is to the shape of a bell. So once that is done, I've pushed it up. It's in the shape of a bell. And then I just lock this again so that it doesn't move. And now comes the fourth part. So for the fourth part is the proximal deployment or the opening up of the proximal flange. Now this we are doing in the scope channel itself. I'm not going into the endoscopic vision. I pull this right, and I think this is position is fit enough so that the other part is in the stomach and not somewhere between the stomach or the small bowel. So the last part, we will deploy the distal proximal flange. So what I have done, I have deployed the proximal flange, and now this flange is in the channel. So this is in the channel, the distal end is in the small bowel. And now what I'll do is I'll rotate my scope and push the sheath out so that this whole stent is deployed. Okay. So here I will resort to the endoscopic vision now. I need air. So I think we are done with it.
Okay, nicely done, Praveer. Thank you.
Yes,
So just to be sure, you can see the blue fluid coming out. There is some amount of blood, but that's okay. Blue fluid coming out confirms that this was a fluid that we have instilled in the small bowel. And just to confirm the position, we'll show you on fluoro as well. Please, fluoro, please. Fluoro. So where is the stent? Further, left. So I think there's a lot of can you see the stent? Yeah, can you see it? So this stent has not opened up, but what I can tell you is that within 24 hours, this is going to open up. So there is no need to enter into it and open it up at this point of time. So if there are any questions, we will take those.
yeah, Dr. Praveer, beautifully done. One question is, have you used the easy, have you used the,
Yes.
have you used the Easy Pass balloon, and is it available?
So, yeah, so I'll come to that. So primarily, there are three techniques of doing an EUS GJ. So one is the direct technique where you don't do any installation of fluid, you just go ahead and puncture, and after puncture, you instill fluid. Second technique is the one that we have used. And third technique that is being asked is the double balloon technique. This double balloon, as of now, is not commercially available. It is available in select centers. For research purpose, Dr. Takao Itoi has given it to few centers. But I strongly feel that that technique possibly is foolproof and maybe better than this technique. Though we have done now a good number of cases, and fortunately, we have not encountered a major complication. Yeah.
Yeah, I mean, we've actually improvised and we created an indigenous double balloon. So a couple of centers in Hyderabad, we've used it. And so I think you're, like you said, it is really important that we are entering the jejunum and it's adequately distended and it's not running away from you. So the balloon, we've only done one patient so far with the double balloon, but it does help with the distension.
Yeah.
And
yeah, please.
yeah, my second question to you was, what is for somebody who is wanting to begin the service, what is the worst thing that can happen and how do we deal with that?
Yeah. So I think why the double balloon may play a role or is important is for two reasons. So what you want to avoid in EUS is that the problem is when you instill fluid, the fluid goes off because of peristalsis. So that's the reason you don't get a distended structure, what you want similar to a pseudocyst. And so that's the problem. So you want to fix that problem. So for fixing that problem, double balloon is the way, one. And second, you want to be certain that the segment that you are puncturing is a small bowel and not a colon. So these are the two reasons why you want a balloon. But what I would propose, or what I would suggest, since we don't have this balloon, but applying some simple logic, I think you will rarely puncture a colon, one. And second is by reducing the procedure time, instilling fluid when you are ready to go to puncture, giving a Buscopan, which decreases the peristalsis to some extent, helps you a significant way. So this, because we don't have this balloon, still we have done approximately around 25-30 cases, and this is all without balloon. The worst complication that can happen is the stent, one end in the jejunum, another end in the peritoneum. So this is the worst thing to happen. Then the patient straight away is a surgical candidate, and somehow if you are not able to offer surgery, the patient succumbs.
And I feel the most crucial part is where you pierce the stomach and the jejunum, and it has to happen so quickly that your jejunum doesn't run away from you. So any specific tips you have to offer in that respect?
Yeah, so I think it's again simple logic. The issue is this is not an FNA. Like you go and jab, which you do in FNA. This is what you are trying to do is the cut. You are cutting the stomach as well as cutting the small bowel. So it has to be a gentle movement. It has not to be a jab. If you do a jab, the bowel will obviously going to push off. The second thing is using a wire, which I think destroys the whole thing. So it should be without wire, and again a smooth negotiation of the catheter into the small bowel.
And
Yeah. So again, this somehow surgeons are very much attached to this sort of thing, that where exactly do you make an anastomosis. So I think I usually what I do is the part of the bowel which is nearest to the stomach, there we go. So I don't search for any specific segment of the jejunum or any specific site in the stomach where you need to puncture. So from wherever side, usually you'll find that it's somewhere in the distal body, antrum region. There is the usually, if you see the stent deployed somewhere there only. So the part of the bowel where it is nearest to the stomach, so that's my target.
And would you say for these GJ would make pyloric stents almost invalid, and this to be the standard of care with gastric outlet, malignant gastric outlet obstruction?
Yeah, so I think it's very difficult to make such strong statements. But if you see the literature says if the expected survival of the patient is more than 3 months, then the GJ or surgical GJ, US GJ or surgical GJ is preferred compared to a duodenal stent. So I think in 2022, I'll be covering that in the presentation today. We have a 2 systematic review and a meta-analysis comparing US GJ versus surgical GJ, US GJ versus duodenal stent versus surgical GJ. What is clear is that reintervention rates are more in patients where you do a duodenal stenting. So if the expected survival of the patient is more than 3 months, then it's likely that the stent will get blocked and you will need to redo the procedure. So that's the area where US GJ or surgical GJ would be better compared to a duodenal stent.
Thank you. Any more questions from the audience?
Ravi, what about benign diseases
Yes.
like pancreatic head lesion, which is not malignant?
Yeah,
Group
so-
pancreatitis, like
Yes.
group pancreatitis, would you do GJ?
Yeah, so I think they have already done a patient with group pancreatitis. We have the patient that patient still carries that particular stent. And the reason why we did that, because in some other conference I was mentioning and someone told, why not an angiotube? So that patient was on an angiotube for 7 months. And despite 7 months of an angiotube, the group pancreatitis was not resolving. And that's the time when we thought that we will do an EUSGJ. And after the EUSGJ, I think he gained around the 10 kgs of weight. He's still on that GJ. Obviously, if the group pancreatitis is going to resolve and that edema at the site of the duodenum is going to resolve, you can pull out this stent and this fistula, unfortunately, will close on its own.
Kavir, I have a few more views on how to identify and how to locate the jejunal loop. So can you please modify or correct me? One of the thing is that when you are seeing the liver, you can never see the jejunal loop when you are seeing the liver.
True.
Okay, left lobe of liver.
Yes.
So if you go in the opposite direction,
Yes.
that is when you are more likely to see. Am I correct?
Yes, you are correct.
Second thing, when you are seeing pancreas, you cannot find loop because the loops are definitely transverse mesocolon is below pancreas. So you have to push a little bit more beyond pancreas into stomach.
Yes.
You have to follow the same axis as aorta. You follow along the same line as aorta, go below pancreas, and then now that is where the trouble is, that in the infracolic compartment below pancreas, you will find two structures. One is the transverse colon and second is the small bowel. Okay. Now, identification of a small bowel means we are here today. So we must work our mind more because this is the key. So one of two more tricks I have is that you are inserting the normal unagitated saline. I would suggest insert agitated saline which has bubbles. Because they will be seen the fluid is still because you are sure, unsure. One of the tricks is insert agitated saline with bubbles. They are better seen with water. That is one thought. Means if others have any comment on it.
So I think this tube that we have used looks a very thin tube, maybe just 7 French or so. And unfortunately, we couldn't see this tube. But what you will find that in the jejunum, usually on EUS, you are able to locate the tube as well. So that becomes very convincing. So,
Okay.
and moreover, when you instill fluid, if you can see the fluid just crossing that structure immediately after you're instilling the fluid, it cannot be a colon. It has to be a small bowel. So that's the usual logic that we use.
So if you find the tube, then there is no need to worry about it.
Yes.
But if you don't locate the tube, mostly you should be able to locate the tube.
Yeah. So again, there are 2 more points. One is the size of the small bowel is usually less than 2.5 centimeters, while the
Okay.
size of the colon is usually more than 3 centimeters. Second is the presence of volvulae conventis and hostra, which are incomplete in colon, and volvulae conventis, which are complete in small bowel. Again, to see this, identify this, and be sure would be needs a bit of experience. But I think these are all points in unison which you should take up to make a diagnosis that you are in the small bowel and not in the colon.
One last comment I would like to add on from my side is because I wrote an article. You have to go through greater omentum when you are going from stomach to small bowel, because that will come in between. You are going from supracolic compartment to intracolic compartment. So you have to penetrate through one ligament, and you are going from peritoneal cavity of stomach to peritoneal cavity of small bowel.
Yes, yes.
Whereas the cystogastrostomy is peritoneal, is probably from bare area of stomach to retroperitoneal to retroperitoneal. See, this is a contrast. Both are axial. Both way you place axial assistant. What in one way, Dr. Ravi will you say, sir?
No, if you use radiologic contrast, it'll be much easier to find the small bowel contrast injection.
Yes.
Along with the fluid, you add contrast.
Yeah, so this is what we did actually. The fluid that we used was normal saline with contrast with methylene blue.
Okay.
This is the solution we used. Yes.